Now it's my opportunity to invite our team of presenters to come up to the podium, all from Florida International University from the Herbert Wardheim College of Nursing. Our first presenter is Pedro Greer, who I know likes to go by Jack, and Joe. And those of you who know Spanish know that Pedro does not mean Joe, but we'll go by Joe. And then we have our colleague Onelia Legg, who is an associate professor in Department of Pediatrics and Adolescent Medicine, and David Brown, an assistant professor and chief of the Division of Family Medicine. So we have a great tag team here who promise us they're going to be within their time of 20 minutes, so we'll see.
That's right. Give a Cuban a glass of water and see if they can stay within 20 minutes. Hi, my name's Pedro Jose Greer. I go by Joe. I grew up in the South. Folks down there can't pronounce Pedro. It's as if Vanna White is selling vowels. Becomes Pedro. Anyways, we're from Florida International University. We were one of the very first new millennial medical schools in this country. And we decided that why not start a medical school in the middle of a recession in a state that doesn't value education or social issues and create something new and different. And that's what we tried to do. The importance of social determinants is the core of our entire curriculum. This is integrated along with ethics into every single clinical case that is presented. By academic training, I am a gastroenterologist and a hepatologist. I have completely tried to despecialize. It's no longer being on the transplant team. It's why do we have to treat so many people with hepatitis C? Why aren't we dealing with the social determinants will be the #1 cause of cirrhosis in this country in the next 3 to 4 years, which is metabolic, which is obesity and diabetes. None of these causes are biologic. However, we as physicians sit back and think everything has to be dealt with in a biologic way. The urgency of doing this right now within our profession and within education cannot be underlined enough. Ferguson, Baltimore, those are the same causes as those that we call social determinants of health, which is actually social determinants of disease. Because for those of us that are physicians, I don't remember a whole lot of classes on health. I remember a lot of classes on physiology, pathophysiology, disease, and intervention. But our health issue was tell them to do exercise, vaccinate them, and give them a diet. So no, it's not working. And we have to do something about it. And an earlier presentation from PAHO showed, in I forgot which countries, there was a 30-year disparity in survival. Well, guess what? There's a report that just came out of St. Louis yesterday. And there's zip codes in St. Louis that have a 30-year survival difference within our own country. So we don't really have to go anywhere else. We can deal with it here. And being from the South, it's important. Because, where do I point this thing to? Oh, maybe I hit the right button. I have children, they help me with this. We have Onelia Legg, who was already introduced, who, because she's lived in the United States as long as I have, goes by Lage. And Dr. Brown, who's lived in Miami long enough that now goes by David. So this is our course. Actually, I want to let you know that the first 2 hires that we did, our first was a Hispanic female, our second was an African-American male, both social scientists, that I had to find David because I needed a white guy from New York or we'd be accused of like no diversity whatsoever. The Herbert Wertheim College of Medicine, we graduated our first class in 2013. We are a state-funded university, allopathic. We started actually putting this together in 2007. The importance of the social determinants was underlined by the fact that our social scientists, we went out in the communities 2 years before we sent a medical student there. The 2 years before we started our first class, we then worked with the School of Nursing, the School of Social Work, the School of Law, the School of Public Health. Those are our interdisciplinary teams. We now have included students of the School of Education. And we will continue that with the arts. There are 2 issues in the state of Florida and probably in this country that we have to deal with very seriously. First one is ethics, or lack of. And that's why we start our first 8 weeks with the ethical foundations of medicine, and hoping also to give the students a basis of critical thinking. We don't really prepare them to be critical thinkers in undergraduate. We prepare them really, really well to memorize. And we definitely do not prepare undergraduate pre-med students to work in teams. We tell them just the opposite. You know, do whatever it takes to get into med school. But when you get into med school, let's talk teams. Okay? So let's play in the sandbox, but you can't throw sand in their face. So we're taking a whole culture, and so if you really want to change things and improve this country and improve the health, we have to rethink and not be so medical-centric and look at it from the disease. 1964, my dad bought a station wagon to take us to the New York World's Fair. Between my two sisters, my grandmother, my mother, and my father, he bought one of those station wagons that were the first ones that had the seat facing backwards. That was me. So I got to see everywhere I had been. That's how I look at our profession. We started in a big academic health center, and we looked at people coming towards us. Then we said, let's do outpatient. Then we said, let's go to community. Nowhere have we turned around and looked in the same direction as our communities, nor do we understand them. So we were out there 2 years in the community because we're not trusted folks. We have baggage. We're called academicians. We go in because somebody gave us a grant. And when the grant leaves, so do we. But we have research data. We might share it with you. We might not, but we'll publish it. So one of the commitments that we made, being that we were not going to be a big clinical institution nor a big research institution, was a total commitment to the community. And the communities we're in, we're there in perpetuity. And the way we financed our faculty to be able to do this is a very interesting model that we have, but that's called sustainability. So we're a public university. Our educational mission is education. That is what we do. We have a mission to prepare physicians for our state and for this country. Not to prepare the greatest researcher, not to prepare the greatest clinician, but to prepare the best physicians that know how to work in a team and know what their responsibilities and their knowledge base takes them and how the team, when they can't lead that team. We are completely community-oriented. We are community-dependent. When Lou Brewster, who put together our program, and he was the head of our division, which is called the Division of Policy, Research, and Community Development, went out there. The first thing we did was we had to hire people from the community to show them we were serious. Did you ever try and get a job at a big public institution that's a university and you apply and all you have is a high school degree? Let me show you how far your application goes. It gets shut off right away. So we had to deal internally with a lot of issues, a lot more issues than we had to externally. We now have 180 community partners. Our outreach team actually volunteers in each one of these community institutions. These institutions are the ones that refer the sickest patients in the poorest neighborhoods of Dade County to us. You folks, this is the state of Florida. We rank 41st in the country in health outcome. The county of Dade, Miami, we rank 61st out of 67th in health outcomes. 35% of our population is uninsured. We do not have Medicaid expansion. So our challenges were great. But it doesn't matter where the challenge is. For God's sakes, we can map the human genome. We can transplant the liver, but we can't deal with disparities. We want to work together with other colleges at universities, but we can't get the colleges to work together. We can transplant an organ, but we can't change the schedule. So you have to look at what is our mission and what is our priority in what we're doing. The social determinants of health or of disease are important. What do we emphasize? Community, professionalism. We have no problem putting a student back or expelling a student for lack of professionalism. They are great in that in every single course. Ethics and policy. Ethics is the foundation of doing what is right. It's also the foundation of being the ability to be a critical thinker and look out there and not just say, hepatitis C, X treatment. It doesn't work that way anymore. There's a lot of issues that go on. We launched big ideas. Initially, we were focused on accreditation and a successful match. We were the very first school the LCME came to after 25 years of never accrediting a new medical school, and we have a brand new curriculum. And I'm chairing a department called Humanities, Health, and Society. This was not an easy sell, but it was embraced. And I remember one time going up with our little FIU medical med pin and going up presenting to the LCME before our first class, then having to fly out of Dulles to California for a meeting and being in the elevator and somebody looking at my jacket and saying, "What is flu med?" And I said, no, that's FIU. And by the way, we happen to be the second largest university in the state of Florida, fifth largest in the country, and we have the worst football team of any public university in the southeastern United States. But if you come to our faculty, I will guarantee you free season tickets. Okay? We had a rapid growth. We went from 40 students for 2 years, 80, and then the legislature said, oh, it sounds pretty good, go to 120. Which, by the way, I think two different things need to be added to the social determinants of disease or health: the U.S. Congress and the legislature in the state of Florida. Outreach and community engagement, that is the basis of what we do. That is the core. We have an outreach team that has to sit there and support the efforts of our interdisciplinary teams that go out there. It's not like we can just go out there and visit the patient. You know what? There's follow-up that needs to be done. When we went out there and Lou said, listen, let's see if we can get freezers for these mom-pop shops because of food insecurities and see if we can get fruits and vegetables. Went back a few months later, and what did they have? They used them for storage because we didn't bother to listen. And when they told us, listen, this is Florida. 35% of our business is made in the morning traffic with the kids. Produce is left in the back door. I have one employee. For them to clean it and stock it, I lose 30% of my income for the day. Frito-Lays will just put it in the shelves. So it wasn't a matter of freezers, which we thought was a solution. Once again, the importance of integrating and listening to the community. We are extremely well trained in our science. We're very poorly trained in the issues of the community. And even those of us that have come from other countries and have come here and have grown up in these issues, folks, this is not 1960 anymore. This is a very different time and very different issues and very different problems. And we need to learn from those that we're going to work with. So now we're developing the clinical components. Every single class, as I call a clinical course or clinical presentation, has social determinants and ethics in it. We are integrating completely within the medical school. As a matter of fact, it is the core and the top part of our strategic plan for the year 2015 to 2020 to integrate the entire medical school into what we refer to as neighborhood help, or that's the global picture of it, and do that at every single course. Onelia is the course director, and David was the original faculty that put this all together, so they can answer the detailed questions. I can't pronounce half the words that they say, so. This is the mission of our school. By providing an environment enhanced by diversity, clinical innovation, research, we prepare socially accountable, community-based physicians, scientists, and health professionals who are uniquely qualified to transform the health of our patients and our community. Make it the mission statement of the university, make it the mission statement of your college, and then you have to follow it. You want to tack it on? You can tack it on. It's just going to be an elective. Or do you want to resolve and improve the health of this country? Do you want Ferguson to be put up there with other third world countries? Or Miami? Or any of these other areas? Or do we have enough pride to say, this is what we're going to do? And it was in many ways the most difficult task, and to be frank with everybody here, was within our own profession. You know, that's what happens when you become big and wealthy. But because we are big and wealthy and we have power, and if we do lead with this, with the social determinants and educating our future students, maybe we can make a real effective change in the lives of those that need it the most. We're in a position to do that. Are we brave enough to take that? And I see that we are, and I really, really congratulate the Institute of Medicine. I want to thank Patricia for inviting us here to do this, because this was like, wow, in the hallowed halls. I mean, this is such an honor for us to be here. We thought that we were just a state that gave you Marco Rubio, Jeb Bush, and where Ben Carson and Donald Trump have a house. It's not a political joke. I was not allowed to say this. Diversity. Diversity, I remember back in college, the very first time they called us, I was a physics major, come on by. We're having tutoring. I said, great, I can make some extra money. Oh, no, you're one of the Hispanic students. We can tutor you. Oh, is that how it works? Oh, well, thank you very much. But, you know, diversity actually enhances academic prestige. Diversity is not the issue. Diversity is the vehicle to improve our nation's health. Nationwide, 51% are non-Hispanic white. We have 30%. Nationwide, 4% are Hispanics. We have 34%. Nationwide, 6% are African Americans. We have 11. Oh my God, you know what? That looks pretty much like the community of South Florida. Isn't that amazing? Yeah, but you know what? That's just diversity. How do they do? Well, let's see. Compared to the nation, we have 51% females, 9% from our state. MCAT's a little lower, GPA a little lower. How did they do in their step ones? Well, I'll be damned. They did better. How did that happen? Well, maybe it's when you concentrate on education, people do well. Having said that, I'm not too impressed with the step ones or the MCATs. I mean, why do we need so much chemistry to go to med school? For God's sakes, what do we know, the Krebs cycle? I mean, unless you're going into, basic science research or you're going to be a pharmacologist, really? 2 years of chemistry? You can get into grad school in chemistry with that. How about some social sciences? How about some liberal arts? How about something that'll teach you critical thinking, something that'll make you understand about the rest of society? What is it, 70% of American medical students or something of that nature come from families that make $250,000 a year or more? That's doing pretty damn well unless you live in Manhattan, So you have to turn around and say, are we really pulling from a pool of all this great knowledge this country has to offer us and solutions? So when we talk social determinants, we got to look at ourselves as being one of those issues and be willing to turn these things around. We have 8 points above the national mean, 74% of our students scored above the national mean, 24% greater than one standard deviation above. Oh, and by the way, we did have a 100% pass rate. Here's our curricular map, which I'll go over very quickly. This is done by our curriculum committee. We have 4 strands. All of them are longitudinal: human biology, disease, illness, and injury, clinical medicine, professional development, and medicine society. We work extremely closely with our strand leaders in every single one of these 4 strands. The basic sciences have ethical questions and social determinants. And for a physician, social determinants are not so much just the cause of disease, but the importance of understanding social determinants for the intervention of disease. If somebody can't get to rehab, they aren't going to go through rehab. In one of our communities, it was one of the poorest communities, they had the highest rates of metastatic breast cancer in women under the age of 55 in the state of Florida, 3rd highest in the country. And when we got there, it was, well, there's mammograms, but there's no transportation. Well, the county told us there was transportation. Yeah, there is transportation. It takes you 3 hours and 5 buses. Okay? And there's no daycare, so you got to take your kids with you. So there wasn't. And it was just, oh, and by the way, doc, I have Medicaid or I'm uninsured. If my mammogram is positive, it's a 9-month wait to the public hospital. By then, it's metastatic. That's the reality we're living in. Unless we address those things, and by the way, I wasn't trained in any of that in medical school. And when we first gave our presentation on what we wanted to do, Dr. Brewster, who runs our whole community program, came up to me and said, I really like what you're doing. I don't think you know what the hell you're doing. So I hired him right there on the spot. Because he was right. I'm not trained in this area. I see the consequences of these things. And if we're in a position that we can make change and prepare the future workforce of doctors to really improve the lives and the quality of lives of our patients, not just deal with a disease, then we've done what we're supposed to do. And as you can see, the bottom line, which is our community engaged physician, or we start here in ethics, the social, economic, and cultural aspects of health, which from the very beginning on is when we start talking about social determinants. Here, they not only learn about the cultural aspects, because, there's a lot of folks who'll come to Miami and say, Hispanics. Well, the Argentinian doesn't look quite like the Bolivian. One's got an Italian last name, and for God's sakes, I'm Cuban Irish. I'm Cubish. Where the hell did that come from? We have just as much diversity within our ethnicities as others. So we go through all these things. They learn here how to map communities and how to measure communities, and they continue that. With the community engaged physician, which then continues on, as you can see the courses as they go through their 2nd, 3rd year, and in the 4th year, and that's the center right there, our students with this interdisciplinary team are assigned the poorest households in the community, period. Referred to us by the community. A school teacher might call and say, Johnny hasn't been in class for a week. We send our outreach team. We find out because he's got a chronically ill elderly person. They can't afford to take care of dementia. Somebody's got to stay home and take care of him. Johnny misses school. There goes his earning potential. There's something wrong with that system. This is Dade County. If you live within a mile of a bus stop, it's considered you don't need a bus to take you to school. For God's sakes, it rains half the time out there. Try walking that mile. So we need to be able to deal with all these issues. These households are assigned to the students. The students in this interdisciplinary team then become responsible for this household throughout their entire career as students. So they have longitudinal care that they learn, interdisciplinary teamwork, and community health. all by doing this and integrating this, going back in their clerkships and in the different cases that they present. Lou taught us at the very beginning, he goes, let me tell you the problem with medical schools, Joe. I said, what's the problem with medical schools? Well, this is what I want to hear from a social scientist. I hear it from my wife, tell me the problems. He goes, you guys go into neighborhoods and you knock on doors and say, what do you need? And they say, there's a foreclosure issue, I need a job. I have somebody with a substance abuse problem, there's behavioral issues, there's crime. And what do you guys do? You come back a year later with your surveys and you say, we're going to build you a clinic. Because we found out you have these rates off the wall, but we didn't ask for a clinic. Yeah, but that's what we know you need. So when we go in there and they say it's a foreclosure issue, the law student jumps in. We're bringing in education students because what did the family say? We need tutors to help our kids. Our medical students were all gung-ho to do the tutoring. They have other responsibilities. And what happens when they go on their externships? Or what happens when they're in a clerkship that they can't show up at 5 o'clock in the afternoon because they're doing surgery? So we brought in students from another college. In other words, the interdisciplinary team to deal with social determinants has to go far beyond what we traditionally have as interdisciplinary teams. So that's how we set that up. And the student then learns. That's what you do. One of the things we're developing right now, and hopefully we'll launch in the next couple of months, is a social dashboard for the electronic medical record. I really don't expect an orthopedic surgeon to understand social determinants. I expect them to understand very little except the cost of a car. But and mostly Italian cars. But what they do need to understand, if it says food inequity or if it says transportation issues, that their patient can't get to rehab. So that physician will then know where to go and what to do. Because just writing a prescription isn't going to solve those problems anymore. This is our Medicine and Society strand, the one we have. We were the Department of Humanities, Health, and Society. The Department of Medicine decided to join us, so now we have internal medicine, family and community health, policy, research, and community development. That's highlighted and underlined because that's a social scientist. EHA is ethics, history, and arts, and now we're starting a program with arts in the households, and the last one is library sciences because they had nowhere else to go. Dr. Brown is dealing with the committee with the EPAs, and he'll talk about that, and how we integrate within our own College of Medicine and around our own university and get everybody involved. I love it when the School of Finance or banks come and say, well, teach them how to manage their money. They say, well, first they actually need money, then you can manage it. So we have to take the perspective, and we have to get rid of our blinders of the world that we live in, because we're taking care of a population that lives in a very different world than we do. Our students come pretty much from the same world we are. Our diversity has allowed us that in one of the families that was asked to join our neighborhood help, this is a great story and a very sad story. They said, oh, we know all about the program. We said, how do you know about the program? Our son's one of the students at the med school, but we have no insurance. So we truly do go to have students come from the areas where we serve, because those are the kind of physicians that are going to make the difference and turn this country around. Why? Well, we haven't done it, and we're showing that diversity enhances academic prestige, and now the next battle we have to fight is to show the basic scientists and the researchers that the social scientists are just as important as the basic sciences. If Fleckner got one thing right, was the importance of science. But you don't limit it to the clinical biologic sciences, you do it to all the sciences. And I'm going to tell you right now, having done bench research, having been on a transplant team, it's a lot easier doing research on a hepatocellular carcinoma, or the different types, than it is in all the moving parts that occur in a society. So if I was deferring, I'd say, let me do the research on the liver, it's a lot easier. Okay, it's just one question, one answer. This is our service learning. We do not do patient-centered care. We do household-centered care. We think the household is the most important measurable unit that causes diseases, whether it is stress, whether it is lack of income, food insecurities, that's where it occurs. We teach social determinants of health / population health. We have interprofessional teams. We have a longitudinal experience. We have continuity of care. And one of the important things we have is reflection. And the students do this every single week. And for the same reasons you saw it in the nursing program, it works with medical students. Neighborhood Help, which is Neighborhood Health Education Learning Program, is about history, about trust, about dependence, and view from the community in, not from us, not for us looking out. We need their voice. We need their intellect. We need their experience. We have 180 community partners. The importance of social scientists to resolve America's health problems, they are major players. And they have to be at the table, or else we're not going to get to where we're going. The overwhelming importance of our communities. This is not somebody we go to join us on a grant. This is somebody that whenever we think about something has to be included in the conversation from day one. And please, please don't get a grant that you're going to be teaching HIV education and prevention, and the faculty member gets 5% of their salary, so they get a few $1,000s, and the community member gets 5% of their salary, so they get $50. Equal work, equal pay. Let's be equitable in what we do and how we do it at every single level. And particularly when you turn around and you see students within your own class coming from families that have these same issues. The other day, one of the secretaries at the school, I got a call from our council that she was being evicted. They had shut off the water in her apartment. She had 3 kids and a chronically ill mother. What do? We sent Lou and his team, our teams, the same teams that go in the neighborhoods there. And the most important thing she said after the fact that they actually resolved the problem temporarily and were working on it was she felt like she had support. She felt there was somebody there. And the outreach workers we have, by the way, all come from the community. We're about to lose one because she just got a great job in Atlanta after she got her undergraduate and master's degree. And now all of them have at the very least an undergraduate degree. And we hire them knowing that one day we hope to lose them, that their careers will progress. So if you're going to work in a community, get in that community early, stay in perpetuity, and work as a team, a real team member. Graduate questions to our students versus those around the country in their exit interviews. Elective experience with service learning, 85 versus 53. Health disparities, 84-61. Elective experience in cultural awareness and competency, 84 versus 64. You can go down the list. Greer strongly disagree with diversity enhanced training. The very last one, interdisciplinary teamwork and community project or service learning, 75.8 versus 23.4 around the rest of the country. We need to catch up. We have the greatest science. We can transplant organs. Let's build that bridge that everybody has access to this. Let's work to the level of our licensure. We're physicians, there are nurses, there are social workers, there are social scientists. They know things we don't know. It's supposed to work together. We published one paper, not a great paper, but it was a paper. But the most important thing about it was when we did the study we didn't want to use a control group in an intervention in a poor neighborhood. So we used the group that was our outreach team that did not want to be part of the school program. Well, needless to say, the interdisciplinary teams, the students had off-the-wall results with going to the doctor, et cetera, et cetera. Both cohorts had one thing that was not significantly different. They both dropped ER usage by 50%. We stopped one of the most costly interventions in American medicine by 50% without having a doctor, without having somebody that had an undergraduate degree, just by dealing with social determinants. Does that not prove the importance of teaching this, educating and developing our future workforce? We had invited commentary from this what's that place? Hopkins. And right around Baltimore. It teaches medical students the value of preventive medicine, provides longitudinal experience that are often lacking in traditional clinical rotations, encourages interprofessional collaboration and teamwork in addition to offering enduring experiences through community-based service learning, and exposes students to patients in their natural environments. That, in a very much of a nutshell, is who we are, and with that I will leave it up to questions, and these folks right here are the ones with all the answers. I'm the Cuban spokesman. Thank you.